will ask Dr. Levy, who again is the Chief Medical Officer at Foundation Medicine, who will talk on technical and contextual evolution of EHRs. Mia?
Thank you, Dr. Schulman. I appreciate the introduction, and thank you again to everyone for the opportunity to be part of this planning committee. It's bound to be a very exciting day and a half, and we're so happy to have everyone here. I wanted to start off the meeting with giving a little bit of overview of where EHRs are today. Here are my disclosures, and we'll just get started right away. I won't be talking about any of my conflicts today. So the first thing I want everyone to recognize is that when we talk about electronic health records, we're not actually talking about one system. We're actually talking about hundreds of systems that are integrated together. Although we often think of the large electronic health record systems as the major one, the entire hospital system works on a highly integrated system from everything from what we think of as patient charting to food services and transportation and integration of back-end systems. Electronic health records really started out, though, as these transaction systems, largely supporting billing and scheduling as early as the 1970s, and became much more popular and adopted into the 80s and 90s. Then we moved on into what really looked like more of the traditional chart that we had in front of us. And we evolved into clinical documentation systems within our electronic health records that support ordering, the display of results, reports, and the creation of notes as part of inpatient and outpatient care. Electronic health records then also began focusing on quality and safety. The Institute of Medicine to Errors Human report really put a focus on the ways in which that medical errors occur every day. And as such, electronic health records really began to evolve into decision support systems to try to eliminate errors, barcode medication administration to make sure that we had the right patient at the right time, and specimen barcoding, just as some examples of the complex patient safety systems that were put into place in the early 2000s. And then, of course, as we discussed, it's not just one system, it's many systems. And sometimes these are specialty-specific subsystems. And very important to oncology is our radiology systems, our laboratory systems, and our radiation oncology systems, which all have their own flavor and integration points of opportunity. Disease-specific subsystems then became a necessity. And in the past, there may have been vendors who, and still are vendors, who specifically support a disease sub area or a specialty specific area. And over the years, the big box electronic health record vendors have had to adjust to these subsystems and create oncology-specific modules within their larger electronic health record systems, such as chemotherapy treatment management systems, cancer staging systems, and oncology history modules. All of these are incredibly essential to the support of specific diagnoses, but often have challenges with the priorities of an entire electronic health record system over that of a disease-specific subspecialty. And so vendors that support oncology specific workflows often address those workflows much better than those that are in matrix organizations, such as large healthcare systems that need an electronic health record that supports the whole enterprise. But we are seeing ongoing advances in this area, and certainly the vendors are wanting to be responsive to those disease area needs, but have their own governance structure for determining how features are prioritized for development within their applications. Within oncology specifically, and in medical oncology specifically, longitudinal treatment plan management has been a very important and essential feature for an electronic health record that can support oncology care management, especially for radiation oncology and medical oncology, especially with medications, hundreds of which are administered over the course of a patient's treatment plan. This includes automated medication dose calculations, complex treatment scheduling management, sequencing of medications that need to be done one before the other, the integration of safety checks, all of this in a massive library of clinical protocols that include not only the standard of care treatments, of which there can be up to 1,000, as well as clinical trial protocols, which depending on the institution can be hundreds to 1,000. And all of these need to be maintained by a staff. This is one of the greatest challenges that remains in oncology care, is the fact that each institution is still largely configuring these treatment plans on their own. And so we have a lot of duplication of effort across institutions where there could be opportunity for knowledge sharing. So knowledge sharing for decision support, especially in longitudinal treatment plan management, continues to be one of the barriers that we have, but the systems themselves have really come a very long way over the last 2 decades. Electronic health records have moved even beyond the concept of transaction systems and documentation systems, or even what we traditionally think of as an order entry system, to also include communication systems. In fact, communication is now one of the main areas of work for the healthcare team, whether they're communicating with one another, the physician to the nurses and the staff, or whether they're communicating directly with the patient through these asynchronous messaging platforms that are HIPAA compliant. I show on the right a social network analysis that one of my students, Brian Seitz, performed back in 2016 of the nature of communication that these messages are showing us. And back then, for every ambulatory appointment, there were 1.9 messages associated with that for the oncologist and 3.5 for the oncology nurse. So the amount of communication that's going on just to support our appointments and the ambulatory care is astronomical. And now with instant messaging, the nurses in the infusion center are now messaging me, in real time with issues with patients as they're happening. It can be quite interruptive. It's kind of hard to focus on what you're doing as a result of the communication, but it is also dramatically decreased the number of phone calls and pages. So it has its trade-offs, and certainly we are being very responsive to the patient's needs. I think you'll see from other speakers later today that those numbers are probably been blown out of the water with the pandemic, because asynchronous communication has been massively adopted by patients during this same period of time, which is incredibly exciting in itself. And on top of that, we see other applications that are now coming in for ongoing patient engagement, including the personal health record that's tethered to the electronic health record system of an individual institution. Unfortunately, it means that when patients go to many institutions, they're still having to log into separate systems for their records. We are seeing the explosion of Internet of Things healthcare devices that are monitoring everything from blood sugar to blood pressure at home, and the adoption of electronic patient-reported outcomes, both for clinical research as well as for standard of care. And this represents an entire opportunity for further understanding what's happening with our patients when they are not in the medical center with us. The health information exchange is also a massive area of innovation that's occurred in the last 2 decades and is really coming to maturity now, where I used to rely on faxes to receive outside medical records, I can now receive from many institutions direct access to a vast majority of the records in their system about my patients, decreasing the burden of patients going between healthcare systems. But I would say this still has a long way to go. And the health information exchange is seen as a vital part of decreasing healthcare cost and improving the quality of care we deliver in the nation. So I'm looking forward to seeing this technology continue to advance. I would also say from a communications perspective, while direct patient messaging and messaging between providers is enabled within a single system, I would challenge us to figure out how to get communication across systems so that physicians can continue to coordinate care of their complex patients across healthcare systems, which is not currently enabled today through the standard mechanisms, and still requires you to page someone and talk to them on the phone, which is never a bad thing. The pandemic has really made an explosion in telehealth and our ability to access patient patients in their home when they may not require an inpatient visit. This has dramatically decreased the burden of patients during the pandemic, and we look forward to seeing these technologies continue to be used into the future. And finally, our research systems, as will be talked about in this session as well, continue to come into our clinical information systems with clinical trial matching, the ability to do case report forms and toxicity reporting, but still have a long way to go before we really start to think of our electronic health records as a system that can support research fully. We're getting mobile systems that are now enabling us to access the electronic health record from wherever we are. It's just like we had our pagers from before, where we're never really off. It's part of the challenge, but we do have amazing access even when we're not tethered to our computers. And finally, I still want to encourage the thoughts of the vision that we're all trying to get to, which is to develop a continuous learning healthcare system where we really can implement our clinical guidelines in our local systems and develop our implementation of our healthcare delivery systems in such a way that the data we're collecting can really be used for analysis downstream and create that virtuous learning system that we're all striving to achieve. We still have a ways to go, but there are still some great examples that are coming out on how this can be done. So with that, I want to thank you and allow our next speaker to start. And we will, again, take questions at the end. So let me pass this along to Dr. Schulman, and thank you all for your time.